Hello everyone, welcome back. Today I'll be covering OSCE question and answer. Happy practice! A 65-year-old male with underlying diabetes mellitus presented with history of pain and swelling of the right little toe for the past 3 weeks. It is associated with past discharge for the past 2 days. Clinically and radiologically as illustrated. The figure shows the view of the right foot with the X-ray of the right foot. Number 1. Define race amputation. It is among the distal or minor amputations for the diabetic foot. Race amputation. It is a removal of the toe and part of the metatarsal bone. Indication include wet or dry gangrene of a toe, osteomyelitis of the metatarsal head and or proximal phalanx, septic arthritis of the metatarsophalangeal joint MTPJ, and gross infection of the toe. Inclusion criteria include 1 or 2 palpable pedal pulses, ankle brachial index ABI more or the same 0.8 and toe brachial index more or the same 0.7. Number 2. Describe record incision. Record incision is one of the techniques used for amputation of the toe. It is named record due to its shape similar to that of a tennis racket. For amputation of the first and fifth toe, the orientation of the handle of the racket is on the medial side or lateral surface of the respective metatarsal head. For the second, third, and fourth toe, the handle of the racket is orientated longitudinally along the dorsal surface of the digit. This first figure shows a racket incision for the first and fifth toe, whereby the orientation is at the medial side or lateral surface of the metatarsal head. For the second picture that shows the racket incision for the second, third, and fourth toe amputation, the handle of the racket is orientated longitudinally along the dorsal surface of the digit. Number 3. How do you do race amputation of the big toe? After the correct indication and full consent taken, patient is done under supine position. Patient is clean and draped. Incision is marked. Preferred a racket incision, extending the handle of the racket to provide exposure of the shaft of the metatarsal. Depends, you can do it under local anesthesia or spinal OGA. The extensor tendon then are divided and allowed to retract, and the shaft of the metatarsal is transected with a power saw or a ronger. Then the distal segment of metatarsals is pulled with a bone hook if cut with saw, and the distal traction is applied while the remaining plantar soft tissue attachments are divided. Care is taken to stay close to the bone to avoid injury to adjacent digital artery and nerve. Sesamoid bones are excised and the flexor tendons are transected under tension to facilitate retraction. Wound is properly washed and closed or leave it open if there is a suspected residual infection or the soft tissue is not satisfying in nature. This figure shows the example of post-race amputation of the second toe of the right foot. The structures are divided as illustrated and the fat pads are separated. Number 4. What is the complication of excessive first metatarsal bone resection? In comparison to the lateral forays, the first metatarsal and great toe contribute disproportionately to the mechanics of normal ambulation. In a normal stride, the foot contacts the ground on the posterolateral aspect of the heel. The weight is transferred progressively along the lateral plantar surface of the foot and then across the metatarsal head from the lateral to medial. Finally, the foot lifts off primarily from the first metatarsal head and the great toe. So, the answer for this question is amputation of the great toe and first metatarsal head excessively could lead to alteration of normal ambulation and may result in destructive force within the architecture of the foot. Recurrent ulceration has been reported up to 60% of patients. Yay! We have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.